Good evening, everyone. On behalf of Indian Academy of Otorhinolaryngology Head and Neck Surgery, IAOHNS, it gives me immense pleasure to welcome you all to the very first Young IAOHNS webinar. Thank you for joining us this evening and being part of what we truly believe is the beginning of an exciting and meaningful academic journey. IAOHNS was conceived as a platform by young ENT surgeons for young ENT surgeons. A space to learn, share ideas, discuss contemporary topics, and grow together as a community. This initiative reflects the energy, curiosity, and the academic commitment of the younger generation within IAOHNS. And we are delighted to see such enthusiastic participation today. At this juncture, it is my privilege to introduce our IAOHNS President, Dr. Srinivas Kamath. Dr. Srinivas Kamath is a brilliant, dynamic young ENT surgeon from Kasaragod with a specialized training in head and neck surgery, sleep apnea surgery, and implantation otology. He is known not only for his clinical excellence, but also for his strong academic orientation and commitment to advancing ENT practice. What truly makes him the right person to lead IAOHNS? Along with the group of like-minded colleagues, he represents the spirit and the purpose of IAOHNS. And we are confident that under his leadership, this forum will grow into a strong and impactful academic forum. Before we proceed further, it would be most appropriate to seek guidance and blessings from our senior leader. I would now like to request Professor Mohan Kameshwaran sir, our chairman of IAOHNS, to share a few words with us, sir. Sir's constant encouragement and visionary leadership have been instrumental in shaping this young IAOHNS forum, and it would be an honor to hear from him as we inaugurate this new initiative. Thank you all once again, and welcome to your IAOHNS journey. Over to you, sir.
Thank you, Vijay. Good evening to one and all of you. It's really a very, very happy day for me because today's program is something which is extremely dear to my heart. The whole concept of the Indian Academy is to actually give emphasis to academic interaction between ENT surgeons. And young IAOHNS is probably the best example of that. It's a program, as Vijay said, is conceived by youngsters and it's meant for youngsters. And it's in a spirit of, participation and friendship that you share each other's knowledge and experience and skills. And today, I think is particularly important because they've chosen a very, very, very contemporary and important topic, thyroid, and talk on the surgical aspect of a thyroid nodule, as well as radio ablation, two very burning topics. And this exemplifies what is going to follow in the future. So I am particularly pleased by the fact that all of you here are speaking, and many of you are going to be listening. And all of few of us who are from the senior category, all of us are going to be learning today from these stalwarts who are young but extremely skillful, knowledgeable, and experienced. So once again, this is something which is a great initiative. I can only talk in superlatives, and the young leaders who lead the young IAOHNS, Dr. Srinivas Kamath, Dr. Nitika Gupta, and Koka Madhav. All of them are brilliant youngsters, and I think this young IAOHNS is extremely safe in their hands. So best wishes to you all. I'll be sitting and listening and following what's happening and getting myself educated in the process. Thank you all.
Thank you, sir. So now I would request Dr. Srinivas Kamath, IAOHNS President, to say a few words and then start the program.
Good evening, everyone. Thank you, Professor Mohan sir, for those kind words and your unwavering support in making this Young IOHNS vision a reality. Thank you, sir. I take this opportunity to extend our gratitude to all our senior governing body members who have wholeheartedly supported Young IOHNS and our activity. And special thanks to Vijay sir, who even on his busiest days has taken time to guide us every step and is made possible to be here and be what we are today. Now, good evening to all our esteemed seniors, mentors, and my fellow young colleagues. It is the moment of immense pride for me to stand before you virtually as we inaugurate our first academic activity under this platform. Now, why dedicated Young IOHNS wing? The answer lies in the unique transition we face when we are going ahead with our early career as a surgeon. Now, I want to reflect about even my shift from a student to a consultant. I can compare it to that of a life of a bird. For years together in our PG training, we work under mentors, and this serves as a nest and provides us the shelter and sustenance that we need as a nestling. Yet, when we graduate and we come out as a consultant, we are pushed out in the sky like a fledglings expected to soar instantly in the air, although we are not prepared and we still want to catch the wind. Now, IOHNS has dedicated a wing for us, that is Young IOHNS. Now, this lays the foundation for our specialty and also make sure we have a future proofing for the young ENT surgeons. Now, we are the generation who are operating at an intersection between the traditional surgical excellence as well as the rapid technological evolution that we are coming across. And we need a space to speak out our language. We want to focus on the steep learning curves of the new subspecialties, the nuances of establishing a private practice, and the integration of digital health in our clinical establishment. Now, with this goal, we have started Young IOHNS, and I would like to share the core ideologies of Young IOHNS. Now, Young IHNS was a platform which was dedicated, as already mentioned, by young minds, envisioned and shaped by young ENT surgeons. The recognition of the need to nurture the future generation of ENT surgeons, the idea was wholeheartedly accepted during our IOHNS National Conference 2024, with the blessing and guidance of all our founding members and the governing body members. Now, who is a Young IOHNS member? Any registered MBBS and postgraduate in ENT who is already a member of IOHNS is considered as a member of Young IOHNS. And who is less than the age of 45 years. Exception are those who are more than 45, but post-graduation practice is less than 5 years. And the core concept is mainly to highlight the education, the bridging the gap, and to represent young ENT surgeons across all regional, state, national, and international workshops to represent young IHNS across different associations. We also aim to improve the research activity to improve and as well as provide opportunities for young practitioners to learn from the seniors, get the opportunity to publish more resourceful literature into international publications. Now, what makes Young IOHNS unique? It is curated to give lectures which are very helpful during our initial practice. It will help us to manage critical situations in clinical practice. It helps us to learn art of talking to the patients. We'll also focus on improving personal health and mental health to get a good work-life balance. We'll also focus on how to procure instruments and the latest technology for our practice. We'll focus on how to establish a clinical setup or even a hospital. We'll also help them to understand the personal hospital finances and budget business management across the platform. Now we have a very young dynamic executive member or core team for Young IHNS currently. My team consists of Dr. Nitika Gupta, Dr. Madhav Koka, Dr. Anukaran Mahajan, Dr. Kamal Pandian, and Dr. Shilpa K. Nair. Along with the core members, we have zonal secretaries of each zone, we'll have 2 or 3 secretaries who will make sure our work is reaching to the right people. Now, we have subcommittees which will be led by the core members and other members who are yet to join. So, we will be having committees under scientific committee, liaison or networking committee, conference committee, midterm young IOHNS committee, career mentorship committee, and journal committee. Now, each committee will be led with a particular aim. The scientific committee will be responsible for curating academic content, planning symposiums, workshops, ensuring evidence-based management, and tailoring young ENT surgeons to practice this evidence-based knowledge practice. Liaison committee would be acting as a bridge between young IOHNS, parent IOHNS body, and international other specialty associations, and fostering collaborations and representation along the international platforms. Conference committee will be able to make more coordination between the organizing committee of the conference of both national and regional conferences, help them to learn the logistics and ensure active participations of young surgeons in this scientific deliberations. Midterm Young IOHNS is a future plan wherein we want to dedicate a midterm national conference led purely by the young ENT surgeons. Career Mentorship Committee is mainly to provide structured mentorship program, guidance to subspecialty training, career pathways, and leadership development for young budding ENT surgeons. Research Committee encourages and supports research initiatives, multicentric studies, and publications by young ENT surgeons, fostering a culture for innovation and academic contributions. Now, how can you become a young IOHNS member? By becoming a IOHNS member, you are directly becoming a young IOHNS member. We would also like to have active participants in our young IOHNS team. So to become part of our young IOHNS team, I request you to fill this form, wherein we'll get to know your field of interest, and if at all we want to work on those subspecialty, we know whom to contact. Now, if you dream it, you can team it up is something which we have learned under leadership of Mohan sir. Now, young IOHNS is not just an idea anymore. It is our shared reality, and hopefully we can do justice to this very dedicated young wing of IOHNS, that is young IOHNS. Thank you for the opportunity, sir.
Thank you. Thank you, Srinivas. Now I would request Mohan Commission sir to introduce the first speaker and start the program, sir. Can you have the slide of the speaker?
Thank you very much, Vijay. It's really a great pleasure for me to introduce a very young, dynamic ENT surgeon who's also a very competent and well-known head and neck surgeon, Dr. Anthony Raj James, who is now currently working as assistant professor in the Department of Surgical Oncology at the Tata Memorial Center in Mumbai. He's a very well-known surgical oncologist, and as is known. Actually, I think he needs very little introduction to this crowd, but he specializes in head and neck oncology and manages very advanced surgical problems in this capacity in the Tata Memorial Center. He is also a very dedicated educator and a clinician, and is committed to delivering evidence-based cancer care and mentoring the next generation of surgical oncologists. He is going to be talking today on a very important topic, something which we face almost every ENT surgeon faces from time to time, and this is on the solitary thyroid nodule. He's going to be talking about the surgeon's perspective. So over to you, Dr. Anthony. We really are looking forward to listening to you. I don't want to take more time. Please go ahead.
Is my screen visible, sir?
Yes, it is. It is. Please go ahead.
Thank you very much for that kind introduction, sir. Deeply humbled. So today I'll go straight into the topic, because this topic and 45 minutes is Actually, a little less, but we have to stick to the time. So basically, this thyroid nodule is a huge topic by itself. Today, we are going to be dealing with this a solitary nodule thyroid cancer using the ATA 2025 guidelines, which have been recently published in the last 6 months. And I've taken my references from ATA as well as the book of Randolph. So basically, when a patient comes to you with a thyroid nodule, he comes to you with a complaint of a swelling in the neck. So the main question is, what are we going to do? The first thing is always and always is the history and the physical examination which we do. And there are some certain red flags which actually cause us to, cause alarm, like rapid growth, dysphonia, dysphagia, dyspnea. In addition to all this, the most important thing we need to see is the risk factors. Is there any exposure to head and neck radiation in the childhood? Is there any family history? And then you do a proper physical examination, examine if there is any neck nodes. Of course, whether it is malignant or not, it comes in the next level, but it is better in the initial period to manage these red flags as well as the risk factors and the physical exam, and then you do a laryngoscopy. The first investigation which we usually send for a solitary thyroid nodule is the TSH. So why do we send this thyroid stimulating hormone? Because that is what is going to differentiate whether we are going to go ahead with a scintigraphy or an ultrasound. So the classical school of teaching right from my undergraduate days, a patient comes to you with a solitary thyroid nodule, you do a TSH, and when TSH is low, you do a radionucleotide scan to rule out a toxic adenoma. Why do we do that? Is because a toxic adenoma is rarely malignant, and when TSH is high, it is not that it's going to be always malignant. The rate of malignancy can be 10 to 15%, but then you send him for a high quality ultrasound. And when a pregnant patient comes with a solitary thyroid nodule, you definitely do an ultrasound. So when you actually do a serum TSH and it comes low, you do a radionucleotide scan, and when TSH comes high, you do an ultrasound scan. So, and now in this radionucleotide scan, suppose if it comes as a hot nodule and you have a low or suppressed TSH, means that there is a focal intake, increased intake in this solitary thyroid nodule, and rest of the gland usually appears normal. Most of the time, this is like you have to manage it medically, like manage thyrotoxicosis. Sometimes you can observe it if this patient has asymptomatic and only it is subclinical, and he has come to you only because he noticed a swelling. There is no other symptoms like difficulty in breathing or difficulty in eating. But even in cases where there is a hot nodule, there are certain surgical indications like compression, cosmesis, and there are other suspicious nodule in addition to this solitary nodule. And of course, during pregnancy, we shift to an ultrasound and we don't do a radionucleotide scan. Suppose if it is a cold nodule, this is when the entire thing changes. This cold nodule has a chance of being malignant, and the percentage is a little higher compared to that of a hot nodule. So basically, till now what we have seen is we do a thorough physical examination. The first investigation we send is a TSH. If TSH is low, you do a radionucleotide scan. If TSH is normal or high, we go into an ultrasound. So basically, I deal with most of the time thyroid malignancies. So most of my talk will be on thyroid malignancies, and let's go straight what is happening when the TSH is normal or high and we do an ultrasound, because most of the time when radionucleotide scan comes and hot nodule, the management is medical unless the patient wants it or there is coexisting symptoms. So basically, most of the talk which we are going to be listening today will be on this ATA guidelines. So this ATA guidelines have been following. In 2009, there were 80 recommendations, which were 51 pages with 434 citations. In 2015, it became 101 recommendations. See the number of citations, it had nearly doubled. But in 2025, the number of recommendations have come down, but see the thyroid citations. 1458 means that there is extensive research work going on in thyroid, and these are papers which are present from all over the world. So we are not going to go through all the recommendations. Of course, we don't have time for that. We are going to deal with this solitary thyroid nodule and what can affect its management. So what is the problem we are facing today? See, every 2 out of 3 thyroid nodules which you send for ultrasound, there will be some suspicious feature or the other, and 5 to 7% of them are malignant. The main problem here is which of them are malignant. And also, 1 in every 5 nodules have indeterminate cytology, and this is the area where maximum research has come, and the 2025 guidelines have stressed more on this Bethesda 3 and 4, which we'll be dealing with. The FNAC is the gold standard, but there is around 33% false positive as well as false negative rate. So there are some problems with these nodules. So what we do is, the first thing what we do is we have a comprehensive management. Before, the previous school of thought was a patient comes, thyroid nodule, we operate, we give RI. But now it has become more holistic. They have framed something which is known as the data framework. What is this data framework? Diagnosis, risk assessment, treatment, as well as how you follow it up. So how do you diagnose it? You use an ultrasound, you use FNAC, you use molecular testing, which has been stressed repeatedly in this 88-20-22 guidelines. Once you have a diagnosis, you assess the risk, whether there is a very important stress on active surveillance as well as the RFA in this 88-20-25 guidelines. RFA, we have another separate topic. So we assess the risk. How are we going to treat it? Whether we are going to do lobectomy or total thyroidectomy, prophylactic or therapeutic neck dissection, are we going to give RI? This is what we are going to be dealing with. So previously, in the previous days, the management was basically nodule management. That is, a patient comes to you, a surgeon will operate, and then he's going to send it to a nuclear medicine person, endocrinologist. But now there is a paradigm shift. This is actually a journey. First you diagnose, then you do a shared decision making by talking to the patient, because now less than 1 centimeter nodules, active surveillance is given as equal importance as much as you do lobectomy. So this diagnosis as well as shared decision making and follow up is going to be a paradigm shift, moving away from an isolated index nodule focus to a holistic view of a patient's lifetime. One more important thing we need to know in cases where we are doing thyroid nodule management is, these patients have a very good lifespan. We'll be dealing with that in the forthcoming slide. So now the school of thought has changed. We are going to do surgery as well as we are going to be concentrating on the quality of life of the patient as well as how he is going to live. So the global epidemiology of mainly malignancies is 90% of thyroid nodules are papillary thyroid cancers. Luckily, it has good prognosis. And the thing is, before 1990s, the incidence was low. But then that 1990s was the time when high resolution ultrasound, CT all gained a lot of precedence. And once these investigations came in, we started to detect incidentally subclinical microcarcinomas. The main thing was, in that time from 1990s to 2009, we can see that the incidence tripled, but the problem was the mortality remained flat. There was an increase in diagnosis and mortality remained flat, and there were many autopsy studies which were coming from Sweden, Norway as well as in USA, which showed that there is a lot of people who had papillary thyroid carcinoma. These nodules would have been with them their entire lifespan and they died with that also. Meaning that we are detecting a lot of thyroid microcarcinomas because of these new investigations. Then 2010, 2015, 2009 was the time when a paper by Billy Mora came. So in that paper, what they said was, more than 1 centimeter, you do total thyroidectomy. But then in the period between 2009 to 2015, there was a paradigm shift. There was a paper by Nixon and there was a paper from MSKCC which said that no, that is over diagnosing and over treating the patient for all more than 1 centimeter tumors. You cannot do total thyroid. And then lobectomy became an option from 2010 to 2015. And as we shift to 2016 to 2024, we could see that the incidence of these thyroid carcinomas started plateauing, but this was only in high income countries. And we started shifting to something which is known as the less is more approach. The active surveillance validation slowly started expanding. We'll be dealing with that. And now comes 2025. Now active surveillance for a less than 1 centimeter nodule is being given as equal importance as lobectomy. And also there is a risk-based approach, which we'll be dealing with the forthcoming slides. So the goal now in 2025 for a thyroid malignancy is not just to find cancer, but to identify the disease that will impact survival and quality of life. 88-2025 encourages this biological cancer being distinguished from clinical cancer. So from a surgeon's perspective, you can see that our role is to operate when it changes outcome. Active surveillance 10 years back, definitely not. But now we have so much data which we will be dealing with that we cannot neglect this thing of active surveillance. So this is what we've been talking. The incidence of thyroid cancer, as we can see in this slide, the incidence by this blue graph we can see that it is increasing, but mortality line, the red line, is flat, as we can see from 1990 to 2015. Of course, there are certain risk factors: age more than 55, a metastatic disease, aggressive phenotypes, and then this population level overdiagnosis coexists. This mainly happened, how was mainly in areas of Japan, Korea, where people are very conscious of thyroid nodules. Especially in Japan, the incidence of stomach cancer was very high. So we all know how stomach cancer started detecting early in Japan, because they started introducing screening programs. So the screening program in Japan for full body was around $400. But that time they were not using the USG for the neck, but they just thought USG neck is not going to cost much, and they started even using for neck also. That is when this overdiagnosis started. This started in Japan, Korea, and then it slowly shifted to West also, where this whole body scans included USG neck, and that was one of the major reasons why this population level overdiagnosis started in the 1990s. As the insurances, everything gained precedence, we can see that the diagnosis started increasing. But we can see thyroid cancers have a 98% 5-year survival rate, and of course survival reduces with distant metastasis. So today in 2025, the thyroid nodule is a multidisciplinary approach. A surgeon can't claim that I am the one who is going to do everything, because he cannot do everything, because he is going to operate the patient. I agree. He's the one who's going to first see and diagnose the patient. That also I agree. But he needs a good pathologist, because Bethesda reporting is very important. We need molecular profiling. Molecular profiling has become very important. Of course, the availability of molecular report profiling in tier 2 and tier 3 cities is difficult, but this molecular profiling, as we'll see in the lecture as time goes, is very important. And then we need an endocrinologist. Before, we used to operate and we used to manage the TSH level also, but in today's world where everything is documented and legalities are more, it is better to follow up the patient with an endocrinologist also, where they can actually monitor the patient's TSH suppression, long-term surveillance, especially active surveillance monitoring. And then for systemic therapy for advanced diseases, we need an endocrinologist. Of course, for radioiodine, we need a nuclear medicine and radiologist. This is an irreplaceable part. In addition, we need people for genetic counseling, survivorship programs, financial toxicity management. So this becomes a team approach. So when we already see that the patient has come to OPD and now you have done a USG, now we thought that we will do scintigraphy or USG, now we are going into USG. Now when you're doing USG, how are you going to classify this nodule? Not all nodules are going to be malignant, and you don't need to FNAC all the nodules. So for that, there are 2-3 methods which there is thyroids from America, there is thyroids from Korea, there is a European system. Today we'll deal with only 2 of them, which is the ACR thyroids. This ACR thyroids differentiates these patients based on the nodule's composition, echogenicity, shape, margin. So including all this, they have 5 points: thyroids 1, 2, 3, 4, and 5. And points are given for each feature, as we can see in this slide. For cystic, it is 0, mixed cystic, it is 1, solid. Like this, there is points. But the most important from a surgeon's perspective is not only the score we need. That is, they shouldn't just say that thyroid score is just 5, and thyroid score. They should tell us what are the high risk features are present. Why I am telling you this is, thyroid 5 is more than 7 points. A 6-point thyroid 4 is much different from a 12-point thyroid 5. So that is very important, that you communicate with the radiologist what you want and what are the high risk features and what is the location of the nodule. All this you need to know. So as we see, once you do an USG, now comes the next question: when am I going to put a needle in this nodule? You don't need to put a needle in all the nodules, because that leads to overdiagnosis. So when do you do is the question. So when you see in this, thyroids 1, thyroids 2, thyroids 3 is 3 points, thyroids 4 is 4 to 6 points, thyroids 5 is more than 7 points. These 3 are the areas which I'm going to concentrate on. So a mildly suspicious thyroids 3 nodule, you'll do an FNAC when the lesion size is more than 2.5. For a moderately suspicious nodule, I will do it when the nodule size is more than 1.5. And a highly suspicious nodule, I will do it at 1 centimeter. And of course, a mildly suspicious nodule which is 1.5 or lesser, there is a chance that you can follow up this and you can do ultrasound at intervals of 1, 3 and 6 months. And a moderately suspicious nodule, if it is more than 1 centimeter, you can do ultrasound at 1, 2, 3 and 6 months. And a highly suspicious nodule, though they have given that there is a point more than 0.5 centimeters, or if it is less than 0.5 centimeters, we can follow it up. There are other things which we need to take into account, like the position of the thyroid nodule, which we'll be dealing with the forthcoming slides. So you need to adhere to this thyroid's cutoff size before you plan to put a needle in that patient, because all this is proven. When you see a benign nodule, you can clearly send there is a purely cystic nodule, there is no solid or hypoechoic features. So as we can see, Bethesda 1, or as you can see in this slide, when there is no high risk features present, a purely cystic nodule, then you can actually send the patient back home and tell him to come if there is any, if he develops any symptoms only. And of course, suppose you send this patient for an FNAC, then comes these 6 categories, which is given by Bethesda, and it was updated. It was given in 2017. Now it is updated in 2023, where you have a non-diagnostic one. Non-diagnostic doesn't mean patient is normal. There is a 5 to 10% risk of malignancy, and any non-diagnostic Bethesda, you need to do a repeat ultrasound. When it is benign, then there is a risk of malignancy of 0 to 3. Most probably, this is ultrasound surveillance. The most confusing and the most flustering thing which we are seeing in today's 2025 is Bethesda 3 and Bethesda 4, which is ATP of undetermined significance and this follicular neoplasm. This is where the molecular testing and all the entire paradigm shift is happening. Bethesda 5 is suspicious for malignancy, where the risk of malignancy is 50 to 75%, and there is a debate now, lobectomy or total thyroidectomy. So you have whether there is, first debate is whether you're going to do a surgery or not. The second debate is, if you're doing, first is whether you're going to put an FNAC or not. If you do a FNAC, whether you're going to do a surgery or not. And if you're going to do a surgery, how much extent of surgery you're going to do. These are all the questions for which we need absolute evidence and absolute counseling with the patient before we start. And of course, if Bethesda 6 comes, it is a 97 to 99% risk of malignancy. Even here, even if it is Bethesda 6 and you have a less than 1 centimeter nodule, we have enough evidence to see that we can keep this under follow-up. I will deal with the evidences in the coming topics. So as we move on further, so we just saw the ACR Thyroid's USG classification system. The ATA also has one. So you have always remember, a solid nodule is abnormal until proven otherwise. A solid hypoechoic nodule always needs some investigation or the other. So in your USG report, you're seeing these features written by the ultrasonogram person, like solid, hypoechoic, irregular margins, microcalcifications, taller than wider, rim calcifications, evidence of extrathyroidal extension. Irrespective of the size, I will tell you to do FNAC, mainly because all this data we get is from the Western world, where the follow-up system is good. In our country, due to the population and the patient load we have, it is very, of course we can do it, but it becomes increasingly difficult to keep tabs and follow up all the patients, and we cannot risk a patient being lost to follow up when we are observing this patient, or when he's having a suspicious nodule and we are observing it. So it is very, very important that if you see any of these high risk features, then it's better you FNAC it if it is more than 1 centimeter. Even if it is less than 1 centimeter and you're seeing a nodule or you're able to palpate it, it is better you FNAC it and you find what diagnosis it is. Then you have an intermediate nodule, which is a hypoechoic solid nodule with smooth margins. Again, you FNAC it when it is more than 1 centimeter. And a low risk nodule, which is isoechoic or hyperechoic or a partially cystic with eccentric solid, when you FNAC it more than 1.5. So now a patient has come to you, you have done an ultrasonogram, you have done FNAC, and now we have diagnosed it as malignant. How are we going to integrate it? There is so much. So a patient came to you in step 1, we already dealt with. We have found a suspicious node, we have used ATA as well, or ACR Thyroids, and then you have FNA'd it. Now what are we going to do? We have diagnosed it as malignant. So the first 2 problems are gone. Whether we are going to FNA it or not, done. We now know when to FNA, when not to FNA. Now we have come to the diagnosis part. Even if you diagnose cancer, doesn't mean we need to operate in all the cases. That is what I like to stress on now, because this 2025 guidelines has stressed more on that. I'll tell you about it more then. So I'm including this molecular testing in thyroid cancer so early in our presentation, because this molecular testing has shown to change management in a sizable number of patients. When it was introduced in 2005, 2013, basically they were just seeing BRAF V600E. If BRAF V600E is there, but then it is papillary thyroid cancer and it is aggressive. But now we have enough evidence to show that this BRAF V600E sometimes, and in the new ATA guidelines, they have placed it in the intermediate low category. So now you can see from 2005 to 2014, slowly it shifted to this cancer genomic atlas TCGA, and slowly we started shifting towards this precision cancer treatment, where we started having gene panels like the Thyroid, the Afirma. So it will be too much if we start talking about all that. Basically, when do you need this molecular testing is what you need to know. Most importantly, when we are practicing in Chennai or Mumbai, this is easier to access. But if you are in a district, suppose I'm in Trichy, I'm in Viluppuram, or I am in Sangli in Maharashtra, so I will not have access to this. Even now, it is difficult to access, but we need to know about this because this changes management. So the recommendation 10 of ATA tells that this somatic gene testing doesn't need to be done in all cases, but you need to do it when it can have an influence on surgical decision making. So there are key molecular targets which you need to do where the BRAF V600E. Why? Because BRAF V600E in a Bethesda 5 nodule, which is saying it is suspicious for malignancy, but you don't know which malignancy. But if that Bethesda 5 nodule has BRAF V600E, we know that it is papillary thyroid carcinoma. Suppose a Bethesda 3 nodule has a RAS mutation, then more or less you can be sure that it is a follicular pattern neoplasm. It could be follicular, there should be a hematogenous spread risk. Suppose you are getting TERT, TP50, these are all high risk markers. So suppose there is a less than 1 centimeter nodule and there is a TERT promoter mutation, books say that for a less than 1 centimeter, there is a chance of whether you can do active surveillance or radio frequency ablation. But we are doing molecular testing and we are finding that this less than 1 centimeter nodule is having TERT promoter or TP53, then it's better we do surgery for that case because this has aggressive behavior. And other fusion genes like RET, NTRK, ALK, these are all will be useful when we need them for therapeutic targets. So there are a lot of gene testing panels. This Afirma, there is Thyroid V3, and then now the new generation have come. Basically, we need to know, let's not go into a lot of details on these slides. So basically, there is a rule-in test, there is a rule-out test. So a rule-out test is basically for a Bethesda 3 or 4 nodule. That is, you need to rule out malignancy in these nodules. So as you can see in Bethesda, the percentage of malignancy in a Bethesda 3 or 4 is not as high as a Bethesda 5 or 6 nodule. So we do a rule out test like Afirma to actually exclude malignancy. Whereas in a Bethesda 5 lesion, that is more or less sure, a 50 to 75% chance that it could be malignant. So we can't miss malignancy. So for a Bethesda 5 nodule and you're confused whether it is malignant or not, because that case, doing these molecular testings will definitely change your management, mainly in Bethesda 3 and 4, when there's confusion whether you can observe or you want to do a diagnostic lobectomy, then you can rule out malignancy by using tests like Afirma GSC. Or when you are having a Bethesda 5 nodule and it is 2 centimeter and now you don't know whether you're going to do lobectomy or total thyroidectomy, it is better we do a molecular testing, and if there is any high risk genes, then we can do a total thyroidectomy. This is where molecular testing is going to come into play. So as we can see in this slide, a TERT promoter mutation, especially when it is co-occurring in a BRAF V600E, irrespective of the size of the nodule, your extent of surgery is going to be total thyroidectomy. And then TP53 is a hallmark of dedifferentiation, which will play an important role when we are taking the radioiodine into effect, which we'll see in the forthcoming slides. And surgical implications are also there because this will change our approach from conservative lobectomy to total thyroidectomy. So I've been speaking about lobectomy and total thyroidectomy again and again. I didn't put a specific slide for it specifically because we are going to be dealing with it in all the slides. So the first thing I'd like to say is, now in ATA, less than 1 centimeter, the plan is whether you can do active surveillance or lobectomy. Between 1 to 4 centimeter nodule, the plan is lobectomy or total thyroidectomy, and more than 4 centimeter, it is total thyroidectomy. And of course, less than 1 centimeter, there is plan for radio frequency ablation also, with enough evidence it's given in this. But that's in 1 centimeter nodule with a TERT or TP53 is going to literally change our mode of management. So a molecular, as you can see in the right corner or right lower corner, my perspective is a molecular red flag, a 1 to 4 centimeter PTC with a TERT positive. Definitely in this case, this 1 to 4 centimeter being a gray area, and I have a TERT positive molecular testing also, I will counsel for a total thyroidectomy. Of course, this is going to increase the cost by many fold, but now there are many molecular tests which are in process, which is actually they're planning to reduce the cost, but that will take time. So now this is a case, a 45-year-old female. So mind you, a 45-year-old female, the problem is they will be undergoing menopause at that time. So preserving one side of that nodule might also be very important. It is a 2.2 centimeter right thyroid nodule. 2.2 in a thin individual will actually look big, and patient will be a little scared because you have diagnosed it as Bethesda 3 and it has come as RAS positive. Now the patient is going to be very apprehensive. For us, since we read about all this, we can say that this evidence is there, that evidence is there, but a patient is having a nodule and they are concerned, and now it is our duty to make sure to first calm them down and tell them what we are going to do. Suppose there is a Bethesda 3 nodule and a 45-year-old female, or let's take this could be a 25-year-old female. She's going to be very apprehensive because that is the time they're going to get married, they want to have kids, and thyroid, they know about all this. So now in these cases, when it is Bethesda 3, whether you want to observe this nodule or not, then you can definitely do this NRAS, TERT, TP53, and all that. And when only NRAS comes positive, means that there is a chance that this could be follicular neoplasm, and the plan can be just diagnostic lobectomy. The most important thing is we are saving one side of the lobe. A 2.2 centimeter nodule, which is Bethesda 3, since it is RAS positive, so definitely we are doing a lobectomy. Suppose all these molecular markers came negative, then there is a chance that Bethesda 3 you can also observe and do a repeat ultrasound with FNAC after 6 months. So this molecular testing should be done when it is actually needed only. It is not needed to be done in all the cases, but you can do this molecular testing only in cases where it will alter your plan. So now you're seeing, let's go back from the top. Now patient has come to OPD, you did radioscintigraphy or USG. So you have gone into USG, you have seen the nodule, you have taken the guidelines, you have done FNAC, you have diagnosed malignancy, now this size of the nodule and everything is there. So now we are going to see how we are going to integrate all of that. So first you integrate thyroids and Bethesda, and then you define a risk. And after that, you stratify this risk. To stratify this risk, you need either you can use AJCC staging, but AJCC staging is not going to play a major role in our thing more than this molecular markers. AJCC, there are just two things you need to remember in AJCC, the high risk group. The high risk group is more than 55. Initially, they were saying that any patient more than 45 is high risk and less than 45 was stage 1 and stage 2 only, but now it is more than 50, any patient less than 55, there are two stages only, one stage without distant metastasis, one stage with distant metastasis, and more than 55 we have 4 stages. So now this patient came to you, you have done ultrasound, you have done Bethesda, you want to risk stratify the patient is affording, so you are going to do a genotype, so you are doing a RAS-like mutation is there, then you can do just lobectomy. There is BRAF V600E, still you can do lobectomy. But if there is TERT or TP53, then you are going to do total thyroidectomy with a central neck dissection. We'll come into central neck dissection in the forthcoming slides. And then the surgical plan. So doing this molecular testing helps us to actually plan for active surveillance. Let's go about it as we go in the forthcoming slides. Suppose there is a unilateral disease with a low risk BRAF, you can do a lobectomy. But there is bilateral disease, extrathyroidal extension, high risk genetics are involved, total thyroidectomy is the goal. So these are the molecular changes which can change the operation. BRAF 600E with a TERT positive, RAS only, it's a lobectomy. I am just sounding like a broken tape recorder telling about this again and again because these are the new changes which have come, and I think we need to know more about this now in this era. So RET and NTRK fusions also serve as prognostic markers. Why? You have an advanced malignancy, you have these RET NTRK fusions, then therapeutically you can target these agents in this era of precision cancer treatment, where cancer treatment is not going to be based on a generalized pool of patients, but every individual is going to be treated as an individual approach, not as a group approach. So in this era of precision medicine, we need to make sure that we know about all this in detail. Whether we have access to molecular changes or not, that is a different story, and that is a topic for another day. But using these BRAF V600E RAS will actually change our approach. So there are a lot of subtypes like papillary, follicular, oncocytic. So major things you need to know is papillary, there is more lymphatic spread. In a follicular cancer, there is hematogenous spread. In oncocytic carcinoma, they have low radioiodine avidity, and regional nodes are uncommon unless extensive invasion is present. So why do we need all this? Is because in 2022, the WHO actually reclassified certain tumors. I'll tell you why it is important. So the invasive encapsulated follicular variant of PTC, initially it was classified under papillary thyroid carcinoma, but in the WHO 2022 update, they've changed it to follicular. Why is this important? See, doing the thyroid is easy. We're going to save the recurrent laryngeal nerve, and we are very skilled. We'll save the parathyroids. But for central compartment, all this is very important. We'll be seeing about all that in the forthcoming slides. If this goes under follicular, then the risk is hematogenous. So many cases, you don't need to do a central neck dissection if it is an invasive encapsulated follicular variant of PTC, if it is under FTC, if it is under follicular thyroid carcinoma. And then they've included certain new varieties. Before, there used to be only one group, which is known as the poorly differentiated thyroid cancer. Now they have separated it into differentiated high-grade thyroid carcinoma and poorly differentiated thyroid carcinoma. And of course, oncocytic carcinoma is being given separate precedence and importance in this ATA 2025 guidelines, as there is a separate risk grading for oncocytic carcinoma. So this differentiated high-grade thyroid carcinoma, what is it? I'll come to NIFT-P. So this differentiated high-grade thyroid carcinoma is basically a thyroid carcinoma with solid, trabecular, insular variety of tumors. That is, when you just FNA a nodule and they say that in this FNAC report there is solid features present, trabecular features present, insular features present, there is a criteria which is known as Turin. Turin criteria is mitosis more than 3, tumor necrosis. If that criteria is fulfilled, it is a poorly differentiated high-grade. But if it is a 1 to 4 centimeter nodule with solid trabecular insular variety, you will not get the report as poorly differentiated. Previously, 2017, they used to mention that also papillary thyroid carcinoma with solid trabecular or insular feature. But now, pathologists have changed that to high-grade papillary thyroid carcinoma. And these cancers, irrespective of the size, we are going to do total thyroidectomy no matter what. So the gray area of 1 to 4 centimeter exists for PTC, FTC, oncocytic and all that. But for poorly differentiated and high-grade tumors, definitely we don't have all that. We are going to do only total thyroidectomy for them. That is important. Another criteria, the new thing which was given by Nikiforov was the NIFT-P. This NIFT-P is a non-invasive follicular thyroid neoplasm with a papillary-like nuclear feature. These are actually the features which will classify it as NIFT-P. But what is this NIFT-P? So if you if you're seeing a Bethesda 3 nodule, it is RAS positive, and then you do a diagnostic lobectomy and your diagnosis comes as NIFT-P. So what are you going to do? Mainly, it is an encapsulated tumor. That is, it has not invaded the capsule. It is a low-risk tumor. You don't need to do completion thyroidectomy. So this NIFT-P is something which is being included in 2022. And now they have clearly said that if you're doing lobectomy and it comes as NIFT-P, you can definitely observe that nodule. Now, this is a differentiated high-grade tumor. That is the papillary or follicular carcinoma with more than 5 mitosis. And the main problem with these differentiated high-grade thyroid carcinomas and poorly differentiated thyroid carcinoma is their reduced avidity to radioiodine. Because classical well-differentiated thyroid cancers have good avidity to radioiodine, but high-grade carcinomas have very low avidity to these radioiodine. And so the need of radiotherapy and other chemotherapy options can be explored for these cases if the patient recurs or there is residual disease. Now let's come into the topic which was actually very rudimentary 10 years back, but now it has gained precedence, which is the active surveillance. So in 1993, as we discussed previously, the number of scans because of the screening improved. They started diagnosing a lot of microcarcinomas, but then they realized that this mortality rate was very low. That's when the Japanese in Kuma hospital realized, why can't we observe these less than 1 centimeter nodules? And then they did a lot of trials for a period of 10 years, and they demonstrated more than 90% nodules being stable. That is, patients with cancer, which are less than 1 centimeter, they have lived for 10 years without removing, just observation. Imagine doing that. But the world did not accept it because USA did not do it. And then in 2010 to 2014, the Western started doing it. In MSKCC, a study came in 2011, and then Europe did. So when US and Europe started doing it, everybody started endorsing it. And in ATA 2025, they gave it as an option like, active surveillance can be a reasonable alternative to surgery, but shifting the paradigm from mandatory resection cannot be done. But in 2025, they have given equal precedence to active surveillance as too much as lobectomy. So main thing is you should not think active surveillance as an observation. It is actually an active therapy, because doing less is also doing more. So if you're doing active surveillance, being an active therapy means that you're going to keep the patient in just follow up. If you're going to notice any change in size of nodule or any high risk features, you're going to do an operation. So initially they did it only for less than 1 centimeter nodules, but now there are some studies coming from USA where they have done it up to 2 centimeter nodules. So you can see how are we going to select the patient, right? First, I will tell you whom we will not do any active surveillance. First is a patient with nodal disease, somebody who's having vocal cord palsy, somebody who's having a high grade histology. These people are out. The second thing is whom we'll do it for: a T1A, intrathyroidal, N0, a compliant patient who's willing for follow-up. These are the patients whom I will mainly take for active surveillance. And where molecular markers comes in is here. Suppose this nodule I'm sending for active surveillance to be double sure that this nodule will behave indolent and it will not grow. I will do a TERT promoter, TP53, BRAF V600E, so that when these are positive, then definitely I'm not going to observe this patient or do active surveillance for this patient. I am going to just operate this patient and give radioiodine in the future period. So the active surveillance protocol, how are we going to implement it? You need a high resolution ultrasound. Most important thing, the first one I will tell you is less than 1 centimeter nodule. Okay, up to 1.52 is also fine. But most importantly, posteriorly located nodules, which are close to the recurrent laryngeal nerve, which are close to the trachea, because these nodules, if they grow, they can easily invade the nerve, easily invade the trachea, and that is very dangerous. So for posteriorly located nodules, it's an absolute exclusion, and the exclusion factors which I gave above. So you do ultrasound every 6 months for 1 to 2 years to establish this stability, and then you follow up with serum TSH, and this patient needs an endocrinologist as well as a radiologist to make sure that proper surveillance is done, proper follow-up is done. In India, because of this patient load, the problem is we cannot implement active surveillance as much as in the West or Japan because of our patient load. But with in 2025, I think with our access to phones and every patient having a smartphone, I think we can actually start thinking about active surveillance in especially less than 1 centimeter nodules for beginners. So the ATA recommends for less than 1 centimeter nodule, you can definitely do observation. Of course, all the criteria which we just discussed previously. So this is the data which changed everything. This was not a study which was done with 100 or 200 patients. It was done with 1,200 patients. They realized that over a period of 10 years, 90% of patients, when they observe these nodules, they remain stable. Only 8% exhibited significant increase in size. This significant increase in size was more than 3 millimeters over 10 years. The nodal progression was 3.8% at 10 years, typically in the central compartment, but most of the time surgically salvageable. And there was safety for delayed surgery also. And one more thing, if you look into this graph, we can see that patients who are less than 40 years of age actually had more progression than patients of 60 years. So in this, they realized that if a thyroid nodule less than 1 centimeter is detected in a patient who's more than 60 years old, then you can actually observe these patients. So that is very something which they found out, as we can see in this graph. So you can see in the left lower corner, more than 90% of the nodules are stable at 10 years, and most importantly, nobody died because they were being observed. Yes, sir?
James sir, another 10-15 minutes.
Yeah,
Yeah,
please go
sure.
ahead. Go ahead.
Yes, sir. Yes, sir. So when are we going to exit this active surveillance? When the tumor growth is more than 3 millimeters, when the lesion migrates to the danger triangle, when there is a new lymph node which is appearing, when patient is more anxious, change in preference, and unreliable follow-up adherence. So these are the patients whom we are going to actually not do active surveillance. And most important thing is, every time I like to tell about active surveillance to any patient, the only thing the patient asks me is, sir, so you're telling me that every night I should go sleep with cancer in my neck? So that is something which has actually struck me, that it is difficult to convince patients to observe for active surveillance. As we can see, even the study started in Japan or Korea, there people are actually very conscious about this scar in the neck, and that was the reason people were easy to agree for active surveillance. But in India, we can see that it's difficult to convince patients for active surveillance, and patients more tilt towards the surgical side than for active surveillance, mainly because of the anxiety that every day we have to think that there is a cancer in our neck. And of course, this slide can show that this is also done in Kuma Hospital, that they realize that the blue and red lines are the comparison of complications between immediate surgery and active surveillance. And they found out that in immediate surgery only, the permanent recurrent laryngeal paralysis rate, the hypothyroidism rate were all a lot. And then the L-thyroxine requirement was also more in immediate surgery group. So this active surveillance in a less than 1 centimeter nodule in a young individual who is having an entire life ahead of him, with thyroid being a low disease specific mortality, we can definitely think of active surveillance as one of the options. So this is a case, but due to shortage of time, I'm not going to do the case. So I'll deal with the surgical management now. So before going into thyroid surgery, just three structures you need to know: the trachea, the recurrent laryngeal nerve, the parathyroids. You don't injure these, of course, the carotids, but these three are the most important thing which you should never injure when you are doing a thyroid. So the most important thing is you should know about the danger triangle which lies between the recurrent laryngeal nerve, the parathyroid, and the tubercle of Zucker-Candle. This is where when you put your musky in, the nerve can get stretched, the nerve can get devascularized, or parathyroids can get devascularized. So before any thyroid surgery, this danger triangle and thorough knowledge of the anatomy of the thyroid is very important. And of course, there are a lot of new techniques to preserve the parathyroid.
हे कोणी घेणार नाही ना, मी बसू शकतो ना इथे,
Any thyroid.
आणि हे ना मी केरळाशी कनेक्ट झालोय, केरळाच्या लोकांना माझं भाषण ऐकायचं म्हणून मी.
So any thyroidectomy, one of the most important things which I read in ATA 2025 is the high volume surgeons. So you can see that they call a high volume surgeon when a surgeon operates more than 25. So what they say is, when a surgeon operates more and more cases, he actually knows and he learns from his mistakes, and he knows, most importantly, what not to do. So that's what they say, that when you have an advanced case and when you're early in your career and you're not doing so many thyroid cases a year, it is better we get a help of a senior, and we all grow together, we learn from their expertise. So that is very important that you associate yourself with a high volume surgeon. Of course, if you are a high volume surgeon, it's okay, but when you have an advanced case, it's better you associate yourself with a high volume surgeon, because we have enough evidence to prove that patients who are getting operated with a high volume surgeon, the complication rates are way lesser compared to an intermediate or a low volume surgeon. So the all through the lecture we have been dealing with lobectomy versus thyroidectomy. How are we going to decide that? It's based on tumor size. It's going to be whether it is 1 to 4. So if a tumor is 1 to 4 centimeters, you are going to think about these molecular markers. You are going to think about the location of the nodule. You are going to think if there are nodes, and then decide. Then you are going to see extrathyroidal extension. You are going to see molecular markers. You are going to see the nodal status. And then if there is contralateral nodule and there is a contralateral benign nodule, then you can think of leaving it. But there is a suspicious nodule, it is better to do total thyroidectomy. Think of patient factors also. What patient wants. Most important, with something which we need to work on is think about what the patient wants also, more than what we want. And then the age of the patient, the comorbidities of the patient. Because if suppose a patient who's having diabetes, hypertension, known cardiac risk, and that patient we are doing a lobectomy, suppose there is risk of completion thyroidectomy in this patient, you're going to give general anesthesia twice. So we need to think about that also. And then you need to think about what type of surgery you're going to do. Just a lobectomy, total thyroid, and this staged completion is very important. What is this staged completion? So in this era of intraoperative nerve monitoring, one of the most important things which we can see is, though there is not much difference between visual inspection and intraop nerve monitoring, one small advantage which I have found is, intraop, when we are operating a patient and in ipsilaterally there is a loss of signal or due to stretch or any other reason, there is an opportunity that we know, okay, this nerve is stretched or injured. So why can't we stage the operation? Why can't we close it and go to the opposite side on a later period? This is one of the advantages of intraop nerve monitoring. Of course, intraop nerve monitoring is a huge topic by itself. So when are we going to labor plan thyroid lobectomy? Is an unifocal, intrathyroidal, less than 4 centimeter, clinically no negative, low risk histology, no prior neck radiation, absence of aggressive TERT mutation, low risk of recurrence, then you do a thyroid lobectomy. And of course, this is what precision care is all about. Individualized approach. That is, a 1 to 4 centimeter is the gray area. When Billy Mora said that more than 1 centimeter, you do total thyroid, everybody started doing. Then Nixon said 1 to 4 centimeters. They gave enough data. Data started coming from Memorial Sloan Kettering also. And they found out that this gray area of 1 to 4, hemi and total, not much survival difference, not much recurrence rate. So this individualized approach for this 1 to 4 centimeter nodule, you need to look at the size of the nodule, the molecular marker, most importantly, the location also. If there is a posteriorly located nodule near the recurrent laryngeal nerve, near the trachea, it's located in the isthmus, whether you're going to do a isthmectomy or a total thyroidectomy, all this you need to worry. So all that you need to know in this individualized approach. And of course, total thyroid, gross extrathyroidal, N1, distant metastasis, significant bilateral disease, you'll go ahead with total thyroid. So this is the gray area zone, 1 to 4 centimeter. Again and again, we are dealing with it. Of course, if it becomes TERT positive, we do total thyroidectomy, and then you're going to see a large nodule, which is 3.5 centimeter, having these molecular markers, total thyroidectomy. So this gray zone has become more clear in this ATA 2025, where they have said that age more than 55, aggressive molecular profile, there is a contralateral nodule, then definitely do a total thyroidectomy. And one more thing you need to know is the microscopic extrathyroid. I'll just take another 5 more minutes, Dr. Srinivas. So the microscopic extrathyroidal extension and gross extrathyroidal, microscopic extrathyroidal extension is actually a histologic finding, and there is very limited prognostic impact in isolation, and there is not an automatic indication for total thyroid. Of course, gross extrathyroidal warrants total thyroid with resection. So how are you going to find out this extrathyroidal extension? Is by loss of echogenic capsule lines, obtuse angle with trachea, posterior capsule bulging into the tracheoesophageal groove. All these are signs of extrathyroidal extension. So this is another important thing which I wanted to tell from ATA 2025. A unilateral multifocal nodule. See, we are dealing with solitary thyroid nodule, but if there is a unilateral multifocal nodule, that is in the same lobe, multiple nodules are there. If it is less than 5, still they are saying that we can do lobectomy. But when there are bilateral nodules, it's better we go for total thyroidectomy when the contralateral nodule is highly suspicious or proven to be malignant. And then extensive micro-multifocality, miliary spread more than 5 loci, diffuse sclerosing, then total thyroidectomy. Of course, this follicular pattern tumors who's having RAS, NIFT-P, invasive encapsulated for variant of PTC, safely we can do lobectomy in today's thing. So these molecular markers which are driving the extent of surgery, and then this, I'll conclude with this case. So 42-year-old male who's having a 3.1 centimeter nodule. So this nodule with a BRAF V600E, still we will go ahead with lobectomy only. If it becomes TERT promoter positive, then I will do a total thyroidectomy. So these are the changes which basically we are seeing in ATA. Sir, I think I'll stop with this, sir. I've covered more or less everything, sir.
Thank you. Thank you so much, Dr. Anthony. I think you covered quite a bit. And, they've emphasized all the important salient features, including molecular markers, the location, the extent, and, the role of surgery versus lobectomy versus total thyroidectomy. I think you've done a very exhaustive coverage of the topic. I think there are a couple of questions which I think we'll probably know. I think one question which was asked is very, very practical question, which is what is the cost of molecular testing? And, if you're in a small city, a tier 2 city, how do you go about it? Where do you send it to? I think this is from the president, Dr. Srinivas. Any company or institute which takes care of it, how do you send the USG core biopsy for molecular testing? Is there any particular agency which will take it from you? How do you send it over to them? So could you your thoughts on this?
Yes, sir. So actually safely, that is why I told in my lecture also, beginning only when I opened the topic of molecular markers, the availability in tier 1 cities only is difficult. It is going to be very difficult to bring it to tier 2. But in the recent times, sir, they are opening a lot of satellite centers, sir. This Apharma GCS is now available in Mumbai in 2-3 centers. We have it. Since I'm in Mumbai, I know. In Chennai, I'm not much knowledgeable on where it is, sir. So maybe I can inquire to these people in Afirma in Mumbai and ask them how it is available in Chennai. But the main problem with molecular markers is this is actually Western data, and we don't know the impact and prognosis of this molecular markers, how it's going to behave in an Indian population. Because their gene, of course, there will be similarities, but there is going to be a huge difference when our data comes out, our molecular data comes out. But the struggle in our molecular data is the cost of Afirma is so much that even in an institute they subsidize it, still patient will find it difficult to pay for this molecular marker. This is where we are having problem with actually implementing Afirma or any thyroid V3. Still it is more of a theory than we are actually applying it in our daily life. But the practical approaches are excess for molecular markers, and the cost needs to come down.
What is the cost now, if you don't mind asking? What is the...
Sir, the last when I inquired, it was around 3 to 4 months back, sir. Just for Afirma, they were saying 1.5 to 2 lakhs. Sir. It's very high.
Yeah, right.
Yes, sir. So patient can get the total thyroid done for 80,000 in Mumbai, sir. Right. So they prefer to get the surgery done than to go for molecular markers. Sir. This is where we are having that is where our counseling comes in, I feel, sir.
Yes.
If we can counsel the patient and tell them and give them this evidence and patient understands that, then I think we can bring in more of molecular markers.
So if you're sending it, how do you send it? You take the specimen and how do you send across to the company in Bombay, for example?
Sir, they'll come and take the sample.
They take it. Okay. So you give it to them straight from the OR?
Yes, sir. Yes, sir. Right now, in-house, we don't have it, sir. Okay. Like I am in Actrek, sir. Actrek is in Kargar. Yeah. Parel Center, I'm not sure. But in Kargar, we actually send it outside, sir.
Okay. So I think, that answers the question. We are, there's no doubt molecular markers are going to be extremely helpful in the future. But as of now, we have very, very important limitations, mainly being the cost. I think it's going to be quite some time before, but I'm pretty sure it'll come down because, don't forget that, it's come down in most other areas now. As more and more people ask for it, volume goes up, the cost will come down. So thank you so much. I think, it is an exhaustive, very, very good start for, the lecture series. And I'm pretty sure if you have any more questions, you can directly, mail the speaker. He'll be more than happy to answer questions. So thank you very much once again.
Thank you for having me, sir.
Really are grateful for your talk. Thank you.
Thank you for having me here. Thank you. Thank you for the opportunity.
Over to you, Srinivas.
Thank you, Mohan sir. Yes. Thank you, Mohan sir, for moderating this session. We have distinguished faculty who will be moderating our next session, Dr. Madan Kapre sir. So he is consultant ENT head and neck surgeon, director of Neeti Clinic, Nagpur. With over 40 years of practice, he is Lifetime Achievement Award winner in IAOHNS 2019, Lifetime Achievement Award in Foundation of Head and Neck Oncology. He is outstanding. He's also won the award for outstanding contribution in medical profession in 2020. He is award winner of Service Above Self in Rotary 2006. Then Jeevan Gaurav Puraskar for tribal work in Bharatiya Admikata Sevak Sangh in New Delhi, and he's authored over multiple 4 to 5 textbooks, and he has several publications, original in international as well as national journals. I welcome Professor Madan Kapre sir to this virtual CME, sir. Now I request Madan sir to invite our next speaker. Madan sir.
Yes, good evening, everybody. I'm very pleased to be with you on this beautiful Sunday evening. I wish you were all here where I am now. I'm in Chikaldara and I will start my thyroid workshop as on tomorrow. So we are very much in the thyroid field right now. I'm very happy to introduce Dr. Amrapali K. Pawar. She is MSc ENT. I'm very pleased that you are of an ENT background because we don't have many ENT people coming into head and neck these days. Her current affiliation, she is a senior consultant and HOD at KB Bhabha Municipal Hospital, Bandra, Mumbai. To introduce her briefly, she is trained for thyroid microwave ablation at CCMA Training Center in Amalda, Turkey, under Dr. I can't pronounce it correctly, but Selik, if I'm right.
Yes.
They might pronounce it Chelik. Conducted numerous training workshops. I wish I was on one of your programs, ma'am. This is one area where I would love to learn and have some more experience into this microwave ablation. There are so many things here, but you're going to give a techniques of radio ablation in management of thyroid disorders. As much as everybody else, I'm very keen to hear from you all about microwave ablation. So may I welcome and request Dr. Amrapali to give her talk and enlighten us about this very new and upcoming area where you might probably throw all of us out. As surgeons, we are worried about you. Not really. We are welcoming you. Welcome.
Greetings, Dr. Madan Kapre, sir. And it is a privilege to be talking about thyroid in front of you. And speaking about Chikaldara, I have fond memories of Chikaldara with you, sir. And everything that we have learned from thyroid is from you. So thank you very much for the kind introduction. I would also like to congratulate the young IAOHNS team for such a nice initiative. And thank you for inviting me. I'll share the screen with you now. So I'll begin my talk. Yeah. Is the screen visible?
Yes. Yes, very nicely.
Okay. So the reason why we are talking about thyroid ablation is because of this picture. If you can see, thyroid surgery is a part of every surgeon's dream. Like there has always been fights from the general surgeon. We fight the ENT surgeons, the endocrine surgeons, the onco surgeon, and now even the interventional radiologists are taking our thyroid patients for surgery. So all the more reason why we should at least learn what is thyroid ablation and how it is done. So I'm not able to change my slide for some reason. Yeah. So, so whoever does the thyroid surgery, anyway, whether there is fight or not, everybody of us aim to have the least complications post-surgery. We aim to have a complete elimination of the disease, maintain the physiology of the thyroid gland, and also, last but not the least, maintain the cosmetic appearance of the patient. Now, for this, we have various ablation techniques since times immemorial. So we have this endoscopic thyroidectomy, we have a robotic thyroidectomy, and we have our ablative procedures, which are not new, because in the earlier days, we used to use ethanol injection, which was used mainly for cystic nodules. But these ethanol injections, they had rate, they had a ablation rate of around 60% only and can be used only for cystic nodules. The solid nodules, however, could not be ablated with ethanol. We have our laser ablation, wherein we use the Nd:YAG or the laser fibers, which is rarely used because of the cost involved. Again, we have our HIFU, or the high intensity focused ultrasound, which is again very costly. And compared to the cost, we have a very low volume reduction rate with these type of ablations. So the most popular form of ablations right now is the radio frequency, and more recent is the microwave thyroid ablation. For those who are new to thyroid ablation, this is the radio frequency ablation unit, wherein we use the 18 gauge antenna, and this antenna has a 7 to 10 mm active tip only. So this uses a high frequency electric current through ionic channels, and the mechanism of action is basically using causing thermal tissue necrosis using combination of frictional and conductive heat. This is the microwave ablation unit, wherein ablation unit, and this is the antenna, which is a 16 gauge antenna with a 3.5 mm active distal sharp tip. This whole shaft of the antenna has an anti-adhesion polymer coating, and this is the skin stop to fix the position of the antenna. So to prevent overheating of the shaft, distilled water is continuously circulated. Ice cold water is circulated through these dual channels, which are shown here. So how does microwave ablation act? Basically, the technique of radio frequency ablation and microwave ablation is the same. Only thing is the mechanism of action is different. So here what we do is we create a electromagnetic field around the percutaneous antenna, which causes oscillation of the water molecules. And this oscillation of the water molecules causes thermal heat, which causes thyroid ablation. So what is thyroid microwave ablation? This is an ablation, the thyroid nodule is ablated using a microwave, and it is a safe and effective procedure with the efficacy of almost 91 to 98%. We have to remember here though that it causes progressive nodule shrinkage within 3 to 6 months. And the mechanism of action here is that the tissue temperature is elevated to such an extent as to cause irreversible cellular damage. So this is how the thermal ablation acts. It causes a heat of around 80 to 100 degrees Celsius, which has a cytotoxic effect on the cells, leading to cell death and coagulative necrosis. And this coagulative necrosis tissue is destroyed and phagocytosed by our body's immune system macrophages. Now here we have to remember that we do not let the heat rise above 100 degrees Celsius, because above 100 degrees Celsius is when carbonization of the tissue occurs. And then this carbonized tissue cannot be phagocytosed and we do not get the desired results. So pre-operatively, we do the same investigations as we do for thyroid surgeries, not something different. But here we depend a lot on the ultrasonography and USG guided FNSC. So we basically choose patients up to Thyroid 3 and Bethesda 2. The thyroid ablation is very simple. It consists of 3 steps. We do not give general anesthesia. We prefer to do it under local anesthesia. The patient is in a supine position with the neck extended, and the local anesthesia is given in between the skin and the subcutaneous tissue. The second and the most important step is hydrodissection, and the third step is USG guided thyroid ablation. So we'll learn about this second hydrodissection step. For this, we have to know something about the US ultrasonographic pattern of the thyroid gland. So I'll just show you for those who are not well versed with the ultrasonographic appearance. So this is the isthmus of the thyroid gland and the right thyroid lobe and the left thyroid lobe. This is the common carotid artery, the IJV, and these are the strap muscles of the right and left side, the subcutaneous tissue. Now, as I said, hydrodissection is the most important step because it separates the thyroid nodule, which is our target, from the surrounding important structures. And thus it avoids injury to the important structures. So this is how the thyroid hydrodissection is done. So say this is the thyroid nodule, and this is the needle antenna being inserted, wherein we inject normal saline in between the strap muscles and the thyroid nodule, and we separate it from the surrounding important structures. So if you can see hydrodissection being done in this video. So this is how the saline separates. This is the carotid artery and this is the thyroid nodule. So it is beautifully separating it. This saline is separating it from the important structures. Again, some more videos of hydrodissection being done here. So always keep the tip of the antenna in view. And so this is the carotid artery and this is a thyroid nodule, and we are separating this with hydrodissection. So what do we use for hydrodissection is generally we use the commonly available fluids like the saline, 0.9% saline or 5% dextrose. But the only disadvantages, advantages, it is costly, it is less costly and it is easily available. Disadvantages, the fluid absorption here is fast. So if you are well versed or well used to doing ablation and you can complete it within 10 to 15 minutes, you can use the normal saline. If you are new to this procedure, you use the iso-oncotic fluids, wherein the absorption is slow compared to the crystalloids, and hence the continuity of safe hydrodissection distance is long. So this is what I mean by a safe hydrodissection distance. And if we inject a normal saline, within 5 minutes, the hydrodissection distance shrinks to this level. And in 20 minutes, it hardly remains. So for those who are beginning, I advise them to use some crystalloid fluids for hydrodissection. And now the third step is doing the ablation with the microwave antenna. We can use either of the three approaches, the lateral approach from the lateral side, the transisthmic approach, or the craniocaudal approach. Now, the transisthmic approach and the lateral approach are the more favorite ones, and you can use whatever is convenient to you. Now, there are two techniques of ablation. One is the moving shot technique, which is the most preferred one. And second is the overlapping technique, which is not preferred for obvious reasons. As I told you, we do not want overlapping of the thermal areas, because then the tissue temperature rises above 100 degrees Celsius, we won't get the proper results. So moving shot technique is the most preferred one. And this is a diagrammatic representation of how we do the moving shot technique. Say, this is the thyroid gland and this is the nodule. So we insert our microwave antenna under ultrasonographic guidance to the posterior most and the inferior most part of the thyroid nodule. We ablate this nodule. So we hold it there for 7 seconds, ablate the nodule, and retract this antenna further, because as we know, the active tip is only 3 to 5 mm of the active zone it creates. So we retract the antenna further and again ablate. So nodule by nodule, we ablate we ablate the whole of the thyroid nodule bit by bit. And this way we cover the whole of the thyroid nodule and make sure that not a single amount of normal thyroid, the diseased thyroid gland or the diseased portion of the thyroid nodule is left behind, including the margins. So this is the procedure. If you are using a used antenna, this is generally done. I generally do in the government hospital. So I'm taking a small nick because I'm using a used antenna to introduce the microwave ablation antenna. Then under ultrasonographic guidance, we insert the thyroid 16 gauge microwave thyroid antenna inside. And this is the video of how it is done. So I've introduced this antenna into the posteriormost and the inferiormost part of the nodule here. Once the tip is visible, then I start my ablation, hold it there for 7 seconds, retract the antenna, and move over to ablate the next zone. So I'll show you a complete video of how it is done. So yeah. So I have ablated the inferiormost part of the nodule here. You can see this is the ablated zone. So we ablate each zone for 7 seconds. Retract the antenna. Again ablate. So we see this popcorn-like appearance that forms. So this is how we ablate the whole of the thyroid nodule. So here we have to make sure that we do not over ablate one particular zone and we do not miss the margin. So when I mean overlapping ablation is this. So if we overlap or create a tissue temperature in one of the zones to above 100 degrees Celsius, we are sure to get such type of carbonization channels. And these channels, they do not undergo this coagulative necrosis and do not undergo phagocytosis, and that is why the nodule shrinkage does not happen post ablation and we get incomplete results. So this is the ultrasonographic picture of the ablated thyroid nodule. This is the immediate picture, ultrasonographic picture of the ablated thyroid nodule. In 1 month, it has shrunk to this size. This is the ultrasonographic picture after 3 months, where in the volume of the thyroid nodule has shrunk from 5.40 to 3.75 ml. And this is the ablated USG picture of wherein the volume has reduced to almost 0.96 ml post 6 months. So how do we evaluate the efficacy of our ablated nodule? For this, first of all, we always calculate the nodule volume. This, you need not remember this formula because this nodule volume is calculated under ultrasonographic guidance. And once we have the initial volume of the nodule, that is pre-ablation, we subtract it with the final volume, divide it by the initial volume minus 100, and this is how we get the volume reduction rate. So we note that the therapeutic success is achieved when the volume reduction rate is more than 50%. Now we define nodule recurrence as a new blood flow in the ablated area or less than 50% decrease in the volume reduction rate. These are the pictures wherein if the nodules are very soft, you might get immediate result like this on table. This is our result post 1 month of thyroid ablation. Sometimes very huge nodules of around 85 ml also we get a good volume reduction post 6 months or so. Now, all complications associated with thyroid surgery can be associated with radio ablation, although rare because we do it under ultrasonographic guidance. So, if we consider like transient vocal cord paralysis or Horner's syndrome, the major complications generally theoretically are nodule rupture or permanent vocal cord paralysis. But these are always monitored. So you see, post ablation, we always see the normal movement of the vocal cords. If you can see in this video, these ultrasonographic guidance, we can actually see the normal movement of the vocal cords. If they are paralyzed, we are able to see that we have paralyzed one of the vocal cords. So when do we suspect this vocal cord palsy is maybe during the procedure or immediately after ablation. So we have to keep in mind that it might be due to just some RLN thermal injury, or when we are injecting lignocaine, we accidentally, which is very rare, but maybe the lignocaine effect or stretching of the nerve or a hematoma or hydrodissection fluid. But there is an immediate treatment which is known as rescue hydrodissection, wherein we immediately inject 10 to 20 cc of cold 5% dextrose plus 20 milligram of methylprednisolone into the tracheoesophageal groove under USG guidance. And the clinical findings improve within 5 to 10 minutes. So some of the few complications that we have encountered are this. So there was a female who developed this kind of swelling, which was, immediately on the 5th, actually on the 3rd or 4th day. And this swelling started oozing out pus. We actually did a ultrasonography, but the thyroid ablated nodule had no problem. Only the subcutaneous tissue was a little bit infected, which settled down with antibiotics and anti-inflammatory agents. So this settled down after a week to 10 days. And we researched on it, and I conferred that this might have been due to my repeated use of thyroid microwave antenna. And since then, I've started using it for not more than 4 times for a single patient after ATO sterilization. Earlier, we used to use it for 8 to 10 times, but now I use it only up to 4 times. Now, this is another complication that we encountered, but this was a huge thyroid. This is immediately post-ablation, and this is like a bruise that we encountered, but this also settled down on its own in around 8 to 10 days. So, as we discussed, the assessment of nodule post microwave ablation is mainly by the volume reduction rate. And we also, of course, do our free T3, T4, TSH to know whether there are any changes, although most of the times there are not. There are no effect on the thyroid function test post ablations. And then, of course, we note if there are any complications post microwave ablation. Then, what are the factors which give you good results or good nodule resorption? Now, this depends on the volume of the nodule, how well you have actually ablated the margin of the nodule, energy per ml in nodular volume, and blockage of the peripheral blood flow. So volume reduction rate, we have already discussed how to calculate. So if the volume reduction rate is more than 50%, you have achieved a good thyroid ablation. Now, we have to know that the volume reduction rate is inversely proportional to the elastography value. So as the elastography value decreases, the volume reduction rate increases. Again, the elastography value can be calculated on ultrasonographic appearance. So the best candidates for thyroid ablations are those with a spongiform structure, nodules with a liquid component, intense peripheral and intranodal pattern vascularity. As I said, soft nodules with a shear wave elastography of less than 30 kPa and a nodule volume below 10 cc. Now, there are some technical factors also that affect volume reduction rate. Of course, one is the operator skill and experience. Second is we always use low energy, like between 20 to 30 watts. If we use more than that, then we actually lead to carbonization channels, and therefore there is a decrease in the volume reduction rate. It also depends on how well you have ablated the peripheral margins of the thyroid nodule, because margins are the regrowth point. And if you fail to ablate the margins, then we do not achieve the desired results. Of course, ablation of the peripheral margin also depends on how well you have done a hydrodissection. Because if you fear going towards the margin for fear of causing damage to the surrounding structures, then you can't achieve a good result. So techniques of margin, there are various techniques described that is of margin control. These are for the interventional radiologist only. So if you can do an artery first ablation, or we can ablate, do a marginal venous ablation. But the most important here to remember is a good hydrodissection. Now, there are some papers wherein they have actually demonstrated some whether there are any histopathological changes in the thyroid nodule after microwave ablation and its clinical significance. So they actually concluded that the histopathological features of thyroid nodules after microwave ablation varies with time, and there is only coagulated degeneration in the freshly ablated thyroid tissue, and no necrosis is found. Necrosis occurs and progresses to the whole ablation area in all the patients, and this occurs at 6 months after microwave ablation, indicating that the 6th month is an appropriate time for pathological evaluation of the ablated area. There is also a paper wherein they investigated the short and long-term effects of thyroid ablation on the thyroid function test, the thyroglobulin, and the thyroid autoantibodies in euthyroid patients. Now, they concluded that the thyroid antibody levels were not statistically different, whereas the thyroglobulin levels actually decreased compared to the pre-microwave ablated patients. There are no significant effect observed at the 6 months on microwave ablation on the thyroid function test. So Heck et al. Had investigated the effects of ablation on thyroid function in patients with benign thyroid nodules, and they showed that the lab parameters did not change significantly at 3 or 6 months follow-up. Only thing is the thyroid globulin levels increased within 24 hours of the procedure, but they gradually decreased at a 3-month follow-up. And microwave ablation coagulative necrosis in the ablation zone causes this thyroglobulin release in the thyroid cells, which is why the thyroglobulin levels increase within 24 hours, but they get back to normal within 3 months and actually decrease within 3 months of follow-up. So there is something known as, before we conclude this session, there is something known as the RFA heat sink effect that you should all know. Now, the heat sink effect is a phenomena that limits the effectiveness of thyroid ablation when the target lesion, so this is the target lesion, is close to the blood vessel, like, a large blood vessel, which is more than or equal to 3 millimeter. So this flowing blood causes a cooling effect, and therefore it reduces the effectiveness of ablation here. And this phenomena is observed only during radiofrequency thyroid ablation, not in microwave thyroid ablation. Especially you will notice it when the nodule is close to the adjacent to the carotid artery. So that is the reason why they say that always RFA gives rise to incomplete ablation zones, because if there are some vessels nearer to the thyroid nodules, then these zones are not ablated properly, whereas microwave ablation does not have a heat sink effect, and therefore the thyroid nodule is actually uniformly ablated with a microwave antenna. So these are some of the differences between the microwave thyroid ablation and radiofrequency thyroid ablation. Apart from the fact that this is an active and passive ablation, which is technical, microwave ablation is shown to be less painful. And as we have seen, the ablation range is larger and the ablation time is shorter. The tumor inactivation is more complete because it has no heat sink effect. It can uniformly inactivate the tumor target area near the blood vessel. Also, another advantage is you can use multiple microwave energy sources at the same time without mutual interference phenomena. Also, the most important point of difference between microwave thyroid ablation and the radiofrequency ablation is it can be used in patients with pacemakers, in patients with epilepsy, and in pregnant women. Now, radiofrequency ablation has a safety advantage because it has this sensors and needles that can sense the impedance and temperature of the surrounding tissue. And so this heat sink effect is actually good for beginners because it actually won't ablate the tissue which is near to the carotid artery. So even if there is a little bit of incomplete ablation, that's okay, but we don't damage any surrounding structures. So to conclude, the advantages of thyroid ablation are physiologically the whole thyroid gland is protected because we ablate only the nodule of the affected nodule of the thyroid gland. Patients do not need to undergo lifelong thyroid replacement therapy. There are no incisions and scars on the skin. It is under local anesthesia. We do not use general anesthesia, so it can be an outpatient procedure. Patient can be discharged after 2 hours. The only post-operative care needed is ice cold fomentation we give post ablation and some analgesics. So in conclusion, the advantages are it is extremely effective in reducing the size of the lesion, has good cosmetic result, brief hospitalization, protects the patient's normal thyroid function, has less complications, and can be done in pregnant women, in patients with pacemakers and epilepsy also. Thank you. That was all about thyroid ablation.
Hello.
Yeah.
Hello.
Yes, sir. I can hear you.
Wonderful presentation, Amrapali.
Thank you, sir.
The concepts, the physics, and the simplicity of the procedure, safety of the procedure, you have explained brilliantly. Just a couple of questions from my side before you take question. Dr. Srinivasan, can you ask questions? Is it allowed?
Yes, sir. Yes, sir. Please, sir.
Yeah.
Great.
Okay. Couple of questions. Number one, I would like to know about the training facilities, if you have any, because I got lots of inquiries coming at various workshops, and they are very keen to learn this technique. Can you recommend some place where they can be having a sort of have the training for this procedure? Because people at my age, we are not able to help them much with the technical backup support. And the second question I would like to ask you is your selection criteria and your sort of preferred nodules for the beginner. Can you just talk a little bit on these two lines?
Yes, sir. So regarding the training facilities, there is a CCMA, that is the center, training center, but it is not a center as such. It is just a Chinese company which has given a third party rights to this center. I mean, it is just a one person thing. And we have conducted our workshops under the banner of CCMA earlier, after I just returned from Turkey. And if there are more, then they are liable to conduct them. But in India as such, there are no training centers. There are training centers in Turkey where I've learned from Dr. Bulen Selik.
Yeah.
And there are training centers in China and I think in Egypt. But I think Korea.
Yeah.
So
You know
if
why I
want
asked you the
to-
question?
Huh.
As I told you in the beginning, we are conducting the workshop in Chikaldara where I am right now.
Yes.
And I'm likely to be asked this question. So if
Yes.
you have anything which you can send me on a PDF or a slide
Sure, sir.
format, I
Sure,
can
sir.
project that through the talks tomorrow and day after. That
Sure,
will be
sir.
great for the students here.
Sure, sir. I can send you this presentation itself. No
Brilliant.
problem.
And once again, congratulations. Very
Thank
well
you.
done.
Thank you.
So
Thank you,
proud
sir.
of you now. And
Thank
I
you, sir.
think this is the technique which all new people must try to adopt, learn. And I like your last slide, save your thyroid.
Thanks, sir.
That's very nice. That's very nice.
Yeah. So
Dr. Srinivasan, do you
Yes,
have
sir.
any questions from the
Yes, sir.
chat box or
Sir,
somewhere which we
there's a
can ask her?
question. Yes, sir. So there's a question regarding what is the follow-up protocol after radio ablation? Do you follow up on routine basis, ultrasound, any blood assessment? And when do you consider the ablation has been successful and you stop the follow-up? And when do you consider it as failure or whether you need to redo the ablation? When do you take that call?
okay. So the follow-up is always on the first month, the third month, and the sixth month. And if you, because generally within 6 months, the ablation is complete. And if you think the ablation is not complete, at the 9th month. Okay, so as we have seen from my earlier slides, the histopathological ablation is complete on the 6th month itself. We generally get shrinkage of the nodule cosmetically within the first 3 months, depending on the elasticity of the nodule, that is the softness or the hardness of the nodule. Okay, we always follow up on ultrasonography. So on ultrasonography, we see the ablated thyroid nodule. So the radiologists are able to properly, and if you are experienced, of course, you will be, if you're doing a thyroid ablation, you will be able to see the ablated nodule, or it is slightly hypoechoic. And so we do an ultrasonographic follow-up only. We do not need to do thyroid function test, or every time. We can do it post maybe 1 month, just for to be sure that there is no hypo or hypothyroidism. But generally there are no effects on the thyroid function test. So my follow-up is only with an ultrasonography, nothing else other than the patient's complaint. If the patients complain of anything, we can always go in for a follow-up. Secondly, about the redoing of the procedure, supposing we have done a huge thyroid nodule and we feel that it is incompletely ablated, supposing we feel that it is not completely ablated, we can do a reablation or plan a reablation after 9 months, because that is when the whole of the thyroid ablation is complete, or the coagulative necrosis, the phagocytosis of the coagulated tissue is completed within 6 to 9 months. And after 9 months, we can redo the ablation, or even post the patient for surgery if you're not completely happy with the procedure.
That's excellently explained. Any more questions? Any from the chat box, Srinivasan?
Yes, sir. The recent trends of advertising radio ablation for treatment of multinodular goiter. Your take on the tissue debulking or size reduction?
Yes. So we can very well ablate multinodular goiter. The problem here is that, say there are 3 or 4 nodules or nodules on both the sides. So the protocol here is, first we ablate the nodules on one side of the gland, and on the second sitting we ablate the nodules on the other side. The reason is just to be sure that we do not create any complications like injuring the recurrent laryngeal nerve. That's what I learned from my interventional radiologist friends who are experienced in the technique. So they ablate after 1 month. Secondly, ablating multinodular, if there are like more than 3 or 4 nodules, it becomes quite a tedious thing to ablate each and every nodule completely. It takes more time probably. So you can ablate. There is absolutely no contraindication to ablating a multinodular goiter. But we have to weigh the pros and cons. We are not interventional radiologists. We are thyroid surgeons first. So we have to see the convenience of the procedure for the patient, whether thyroidectomy would benefit him or an ablation would benefit him. Because again, ablating the multinodular goiter, the antenna itself cost 90,000 or 1,20,000 rupees. Even if you reuse it, you have to pay at least more than half the price. So that is the main disadvantage. So you have to weigh the pros and cons. There is absolutely no contraindication to ablating a multinodular goiter. Again, as I've explained in the pros of microwave ablation, you can use multiple antennae to ablate at the same time. But again, the cost involved is there. So you have, as a thyroid surgeon, you have to think from the patient's point of view also. What will be the more convenient thing for the patient?
Yeah, can I come in here, Srinivasan, on the size and multinodularity? Like the remote access, endoscopic, robotic, and what have you surgeries, they have come essentially for 2 reasons: the cosmetic reasons and probably the safety of the procedure. I think not to give wrong signals to the audience, we are still not very sure if this procedure will be good for multinodularity or a goiter which is larger, because the cosmesis may not be served the best purpose with multiple sittings and multiple costing of it. I think still reserve this procedure in my books. Maybe I am a little older, but for a smaller size, benign, proved with all the available techniques, and then go for it and give the best result to your patient.
Perfectly
No doubt that this will save the rest of the thyroid tissue apart from nodule on that side, also apart from the other side, which is not so important probably, but
Right.
from the functionality, 30%, if not more, will eventually become hypothyroid if you do a hemithyroidectomy or a lobectomy.
Yes.
So from that angle, I think this is good. But
Yes.
just last quick word about your own choice, microwave versus RF. What is your choice? What would you say?
I use microwave only, sir. I have learned microwave technique. So I use microwave ablation. It is much safer, as I said, because, and it is much more effective rather than safe. It is much more effective because we can ablate the whole of the nodule. I myself always make sure that I ablate the whole of the margins, because most of the times what happens, when a beginner does it, is afraid. We just think that ablation means just put in a needle and ablate the thyroid tissue randomly. That is not so. There is a technique which I have described, and you go from, again, as I said, posterior to anterior, inferior to superior, so that we ablate all the zones in the thyroid nodule, including the margins. If we are afraid to ablate and we do not ablate the margins, then we don't get the results. And if you don't get the results, you are wasting the patient's time and money. So, and of course, so it does not, if we do not get good results, then it is a waste of time and money. So that is why I prefer microwave ablation.
Nice issue, Amrapali, after a long gap. And well done. Keep it up.
Same here, sir. Thank
we are
you,
always willing to learn from the students as well. And you are a student where I will be very happy to learn both these techniques anytime.
Thanks.
Welcome.
Just
if you are
last
done, my signals are
regarding
getting
anesthesia that is given during the procedure, and the cost dynamics of the testing, I mean the therapeutic ablation, and what is the machine cost and running cost for the
So anesthesia, as I said, we do it under local anesthesia. The patient absolutely does not have any problem. They recommend that if the patient is very anxious, you can give mild sedation. I have never seen an ablation being done under general anesthesia. In our case, like in Indian scenario, we operate in the OT. But when I had gone to Turkey, the interventional radiologist used to do it in his OPD itself. I've learned that in his OPD because everything is available there. Here we have a standby anesthetist. We always keep a standby anesthetist because we are just in the learning phase here. So we do not want to create any problems. So a standby anesthetist is always there, but the procedure is under local anesthesia. Regarding the cost dynamics, as I said, the new antenna cost 1.2 lakhs. The cost of the machine is 30 lakhs. Although if you buy the antenna, they give the machine free along with it, like on rent. They don't take any rent. Or maybe they can charge a 20 or 30K rent at the most. But generally, because it is a very new technique, they want to promote it. If you buy the antenna, then they give the machine for free. So this is the only cost involved. As I said, no post-procedure. We don't even give antibiotics. Nothing else is required. 1 day stay. So overall, if you ask me, in a private setup, it cost in Mumbai, the overall cost comes to around 2 lakh, and that is because I involve the interventional or any radiologist, because in our country we are not supposed to use ultrasonography on our own. So we have to involve a radiologist. So we have to pay him. And sometimes the ultrasonography machine is in a cath lab, and to move it, we require several documentations. So again, the cost of that OT or the cath lab or whatever is involved. So in a private setup in Mumbai, I would say it would cost around 2 lakhs. In BMC, we have done it for free. It is covered under Mahatma Phule Yojana also. Let me tell you that. It is covered under all insurance policies. So that is not a problem.
Yes, ma'am. Thank you.
Well, thank you very much, Amrapali and Dr. Srinivasan. Wonderful evening. I think if there are no questions, shall we close the session?
Yes, sir.
Okay.
I would
Great.
request
Hi,
Madan.
Vijay. Nice to see you.
Nice to
Where
see you,
were
sir.
you?
I was here
You were
only.
in the background.
Yes, sir. How are you, sir?
So, are we done?
I request Dr. Madhav to give a vote of thanks for the event.
Yeah. Good evening, everyone. Respected chairpersons, esteemed speakers, dear seniors, colleagues, and friends. On behalf of the Young IAOHNS, I extend our heartfelt gratitude to our distinguished speakers, Dr. Anthony James Thomas and Dr. Amar Pali, for the insightful presentations on solitary nodule, thyroid nodule, emphasis on molecular genetics, and advanced treatments of thyroid nodules with radioablation techniques, which are hardly dealt during our PG days and early early ENT practice days. The depth of knowledge and concepts will help us in a great way in our clinical practice. Our young IOHNS teams are extremely thankful to both the presenters for taking the time out from their busy schedules to start off this academic initiative. I would also like to thank moderators Dr. Mohan Kameshwaran sir and Dr. Madan Kapre sir for facilitating the meaningful discussion, ensuring a smooth flow and giving a great audience interaction. Today's webinar holds a special significance for us. This is the first webinar of a Young IAOHNS webinar series. I proudly say that we have kick-started very well. So we have 250 plus registrations and we have 200 online participants for today's webinar. I think we need to start clapping for ourselves to go off with a great start for this initiative. So this initiative aims to provide a vibrant academic platform for all the young ENT surgeons and also ENT PTs across the country. We are grateful to the IAOHNS leadership, Dr. Mohan Kameshwaran sir, the chairperson, the chairman of IAOHNS, Dr. Vinod Shah sir, the president, Dr. Vijay Krishnan sir, secretary, for their constant encouragement and support to start off this webinar series. My sincere thanks to the organizing committee, the technical team, and everyone working behind the scenes for ensuring a seamless conduct of this online program. Finally, I thank all the online participants for the enthusiastic participation and also coming out with some doubts so that we had a very good interactive session. With this, I once again thank everyone involved and we look forward for the next topic, and we will soon announce the next topic date and also the topic for the Young IAOHNS webinar. Thanks, everyone. Thank you. Good evening.
Thank you.
Thank you all. I would also like to welcome you all for our forthcoming 12th National Conference of IAOHNS at Jaipur in 25th, 26th, and 27th of September, the Pink City. Welcome you all, and we'll meet in the next IAOHNS webinar. Thank you, one and all.
Thank you. Bye.
Bye, sir.
Thank you.
Recording stopped.
Okay.
So we can